speaker. Professor Alan Lerner, Professor of Neurology at the Case Western Reserve University School of Medicine and Director of the Brain Health and Memory Center, Case Western University School, Medicine and Neurological Institute at University Hospitals, Cleveland Medical Center, Cleveland, USA. Professor Lerner completed his neurology residency training at University Hospitals, Case Western Reserve University, followed by a two-year fellowship focusing on Alzheimer's disease and other dementia. At the time, there were no medication approved for Alzheimer's disease, and neuroimaging was in its infancy. The technological advances in dementia recognition, diagnosis, and treatment have been amazing, yet Dr. Lerner feels we are in the early stage of understanding these disorders and how to treat them with specific targeted interventions. As a result, behavioral neurology is now one of the most dynamic and growing areas in all of neurology. Professor Lerner has an active research program and is developing the Cleveland Brain Health Initiative. He is the co-director of the newly funded Cleveland Alzheimer's Disease Research Center Clinical Core in association with the Cleveland Clinical Foundation and the Louis Stock VA. His clinical practice has also focused on the various dementia, including Alzheimer's disease, frontotemporal dementia, normal pressure hydrocephalus, and treating people with psychiatric and medical comorbidities. Professor Lerner, you have 40 minutes to talk about assessment and management strategies of Alzheimer's disease. Professor, the floor is yours.
Okay. Well, thank you very much. And let's get the PowerPoint and share. And can you see that okay? Yes?
Yes, we can see it.
Good. Okay, whoops, that's not it. Let's go. So we're going to talk about Alzheimer's disease today, which is really moving from a clinical diagnosis to a biological diagnosis. And this is not going to be Alzheimer 101. It's going to be more like 201, which assumes some knowledge about Alzheimer's disease. But we're going to talk about some of the important issues that people in the field are talking about. We have no financial relationships to report for this presentation. We'll be talking about assessing AD, particularly early stages of memory loss, which are often overlooked clinically, and managing AD. And then, very importantly, where do we go from here, including finally the recently approved by the Food and Drug Administration in the United States of aducanumab, which has gotten quite the, been quite a story. So there's, the old Alzheimer's disease versus the new Alzheimer's disease. This was the disease you couldn't tell you had until you were dead. We were told that patients lacked insight. There was no treatment. Nursing home was inevitable. And this has been changed to a model of early recognition and care of attempts to prevent Alzheimer's disease or prevent dementia. It's estimated that up to 50% of cases of dementia may be preventable. We talk about biomarkers, environmental risk factors, the quality of life and lifestyle, brain health, and then we'll talk about the biomarkers as well as aducanumab. So there's a lot of questions when you start to think about dementia. We're going to start with what is normal, what is dementia, how do I evaluate that, and some special tests. So normal has two definitions, and this is important. Normal is can be defined in terms of two things, not we never look, but the first definition of normal relates to the normal curve, the standard deviation, and where you stand relative to some population, means and expectations. And this is the implicit with when people say, well, all my friends have the same problem. All my friends might all have MCI too. That's a possibility. And then there's normal for what is normal for you. And here, SpongeBob SquarePants and Patrick, what is normal for you? And this actually turns out to be a much more powerful comparison because you've got, we know who you are and that hasn't changed. Now, when we think about cognitive aging, we have to think that where actually normal is something of a moving target, but is not a monolith. Okay, and so this is from the Maastricht area aging study, published a number of years ago, which is a population-based study in Maastricht in the Netherlands, and means and standard and you can see that with the exception of vocabulary knowledge, all functions, the Z-scores go down with age. Not surprising, particularly speeded functions. Now, there is something we put in its place, and that's called experience and wisdom, so that although we're slower in doing things, we can use heuristics and shortcuts. But vocabulary knowledge stays relatively stable. Now, this just looks at the standard deviations, the T-scores, the standard deviations, to show that it's really not two populations, it's all one population. So it's this idea of when is over the hill. You can draw your own conclusions on this, but by the late 30s, early 40s, you can already begin to, with sensitive tests, begin to show that. Now, you can see this in professional sports players when they're paying them millions of dollars a year. You already see that some people in their mid to late 30s can't play quite as effectively as they did only a few years before. I also want to talk about the Montreal Cognitive Assessment, and it's a great test, okay? This is not meant to, but it's important when we're talking about normal to understand this. And I would call your attention to this number, and if you can see my pointer, this number down here that normal is 26 out of 30. And we're going to look at this in some information that is just going to be published soon. And so, and why this is so dangerous, okay, to just take that as, and remember, it's the Montreal Cognitive Assessment. And so particularly in underrepresented groups and in people, we have a worldwide population, the norms may change, and this is really important. So I'm going to talk about, so first off, this was from the Dallas Heart Study a number of years ago. They looked at the Montreal Cognitive Assessment by age and education. You can see that in African Americans in America, so this looks at different populations, diverse populations. The mean was almost 3 points lower than in the white populations, and similarly for Hispanics. And that with age, and went up to 80 for people, let's say, with 12 years of education, we're doing medians are well below 26. In fact, for the people who had 12 years of education, the median, which is the 50th percentile, certainly not mild cognitive impairment, was never 26. And so the risk of overdiagnosis of early memory change in diverse populations cannot be overstated. This comes from the SPRINT study. I'm going to talk about SPRINT, which was a hypertension study looking at 120 over 80 versus 140 over 90 that enrolled 9,300 people. And this was extracted from this. And the top three lines are 90th percentile, 50th percentile, and then 10th percentile. And you can see a couple of things that are important, that all the way along, African Americans and Hispanics in this United States population are about 3 points less than the Caucasian population. Education, culture, there are many explanations. The lines are parallel. That's interesting. But you also see that there are changes in age of the 90th, 50th, and 10th percentile. 10th percentile is actually above minus 2 standard deviations, and so could conceivably even be normal. So even 50, if you look at the 50th percentile, and you look at people who are well into their 80s, you're talking about at 85. If you're talking about these are people with 12 years of education, 10th, 50th percentile could be 22. For Caucasians is 22. For African Americans, it's under 20. So a lot of clinics, these people here would be called mild cognitive impairment, even though they're at the median for their age and gender and race. So it's very, very important to think about who you're testing, and this is an important piece. Okay, so why is diagnosing memory loss so hard? And it starts with symptoms are inconsistent. There's denial and fear. There's stigma. Family members, it turns out, we looked at this in the Mirage genetic epidemiology study, turn out to be extremely good. They're over 80%. When family members say that there's a problem, you should know that the likelihood of there being a problem in medical evaluation is about 80 to 85%. So that is quite high. Okay, how is dementia recognized by family members? The most common thing is repetitive questioning, executive functions, get people's attention very quickly, getting lost, finances, those are and driving are the most complicated things that we do happen first. Okay, so that's an important thing. As medical professionals, we look at normative comparisons and we take a history and we try to take a dedicated history. This is labor intensive, and that's everybody's been trying to find maybe the addition of blood-based biomarkers, which are in the process of being validated at the moment, might change this and make the process much easier. We've relied very strongly on short mental status tests, but with the addition of neuropsychological testing when necessary. The clinical assessment of dementia is fairly standard. It may require some extended testing in people with young onset, people in their 50s. You might consider doing spinal fluid, EEGs, other PET scans, etc. Especially people with rapid progression, you consider the possibility of prion disorders and atypical features. So you're looking at some of the non-Alzheimer's dementias, particularly in the younger onset group where frontotemporal dementia is actually more common than early onset Alzheimer's disease. The clinical approach, and one of the biggest complaints against doctors, neurologists included, is that they didn't really talk to me. And so we focus a lot on the clinical approach of who is this person and why is this happening now? So what is their life story? We're learning a lot about early life experiences and the Barker hypothesis, as well as the other data suggesting that early life experiences play an important role. Family structure in terms of caregiving is important. Occupational exposures may sometimes give some clues as to what the people might be having, particularly if they were exposed to hydrocarbons or other metals such as mercury. Education, living arrangements, and obviously previous medical history. Now, the other thing is figuring out, and if you could do this, you're actually doing pretty well. If you can come and get some information about each of the major cognitive domains, you're doing pretty well. And that's where the MoCA comes in. But it's important when you give this history is to really listen. Is it a memory problem? Is it a visual spatial problem? Is it somebody who can't recognize a family member? Yes, that's a memory problem, but it's probably also a visual spatial problem. Language, are they aphasic? People with aphasia tend to do much worse compared to their functional level. Is it executive, behavioral, purely primary psychiatric disorder? So this is really listening to the patient is a key aspect. I know this sounds so low tech, but you'd be surprised how far you can get just by talking to somebody. There are barriers to accurate dementia diagnosis. Symptoms overlap. There's lack of diagnostic biomarkers, which is an area of intense study now, and very insensitive diagnostic criteria. Now, there's the issue of subjective cognitive impairment. So somebody comes, you have evaluated them, you didn't find anything, so it must be on their head or not something. So there've been a number of studies, and terminology varies about subjective cognitive impairment, but this is a study that followed a total of 213 people over a number of years. And you can see that the decline associated with people who complain of this over a period of years, those followed up, 97 out of 213, almost half develop declining cognition and probably, so it turns out that SCI, these are the most valuable people. They're valuable for research because they're early on. They may be amyloid positive or not. But this is actually the most valuable population in terms of people to follow and not just reassure them, but to understand that over time that this may change. And we've had several people who have self-diagnosed and then went on to develop Alzheimer's disease. And there's a number of instruments like the Cognitive Function Index, the CFI, that are optimized for assessment of early memory loss. Now, common question is, does dementia show up on scans? And the simple answer is no. However, different diagnoses may show themselves here. We have some pictures of cerebral microbleeds. This is important for amyloid lowering therapy, as we'll talk about in the end here. Here's a small hemorrhage on the CT scan, and you can see these cerebral microbleeds. And more than 4 microbleeds, at least in the United States, is reason enough not to engage in amyloid lowering therapy because of the increased likelihood of amyloid-related imaging abnormalities, which we'll talk about. The other thing that we have found, particularly in patients over age 85, is that almost 90% of people with dementia have mixed dementia. So the presence of large amounts of white matter change, however you might categorize this, suggests the possibility of mixed dementia. The work of Julie Schneider at Rush has suggested that in autopsy series that almost 90% of people have mixed dementia. So the pure Alzheimer's disease is less than 10%, especially in older populations. I'm not going to get too much into this, the complicated, and I hope that the sponsors here, and I'm very grateful to them, including Dr. Chahidi especially, will make these slides available to you as on a website, or maybe you can contact me directly. Without getting into the technology, the technical terms, there's leukoariosis. You can see silent brain infarcts, and we talked about microbleeds already. And risk factors for vascular disease are very similar to those for primary degenerative dementia: age, high blood pressure, which we'll talk about, diet, diabetes, not PCO. That's more for small vessel disease. Other things that may show up are anterior temporal as well as frontal atrophy, suggestive of frontotemporal lobar degeneration here in the KIPS grading scale, as well as hydrocephalus or focal atrophy. Now, one of the most important things you can do is look at the scans yourself and not rely on the radiologist to give you all the information that you need. Focal atrophy, such as the temporal lobe, may or may not be picked up on routine readings just of the report. So looking at the scans itself and making your own clinical decision and putting it in context is extremely important. And that you can see that ventricular change, the size of the ventricles, the Monroe-Kelly doctrine suggests that the brain, you're in a closed space. If something gets smaller, the brain atrophy with age, then that there's a pretty good ADLs, it turns out, again, function turns out to be a better predictor of decline than MMSE scores. Now, management of Alzheimer's disease, we've relied heavily on cholinesterase inhibitors. And I showed this is from the donepezil Aricept critical studies that got it approved. And the most important thing that I would say here, 2 things. One, this is the placebo group. You can see a little placebo effect with the improvement at 3 weeks. But it's not that this group did so well. It's that the placebo group did so poorly. And we're going to see this over and over again, is that it's not that people get better so much, but that putting them on medication seems to slow it down. That's probably prolonged symptomatic relief rather than a disease-modifying therapy. It turns out that I know aducanumab claims to be a disease-modifying therapy. I haven't looked at it enough, but it's very difficult actually to understand or prove that it's truly a disease-modifying therapy. And this difference between taking it and given enough time, most people who are on donepezil, and we're going to see the same with aducanumab, and it's true with memantine too, is that most people are worse than when they started. However, this difference is net benefit. Now, do I want to stop this to find out that they go down? Not really. So in some ways, we think that this is something that they will probably be on for a very long time. So the medication continues to provide benefit relative to placebo, even for many years. Memantine, voltage dependency, and NMDA, neuroexcitotoxic theory, very important. One thing that to understand about memantine, and it is again important, is memantine is a reversible NMDA and antagonist. With permanent irreversible antagonists, things like ketamine or phencyclidine, angel dust, we can get much more serious things such as psychosis or coma. Though ketamine, which was also a drug of abuse, is now FDA approved in the United States as a nasal spray, S-ketamine, for treatment of acute severe depression. We are at our center, we have been users of what's called the Savvy Caregiver program. This was originally developed at the University of Minnesota and is one of the few validated psychoeducational interventions. It's not a support group, it's six educational sessions. And our caregiver, we give this away to our caregivers because it is A, validated, B, an extremely useful thing, and you can see the word clouds at the beginning and the end of this 6 sessions, from sadness and grief to information, help, understanding, because this is one of the things is that families have never dealt with this. This is really a new thing, and they really need to understand this new normal. Now, we also I'm going to talk about some non-pharma things. So we know that there's changes in the visual system, that AD affects the visual system. Here you can see. Now, what you learn very quickly is if you didn't see it, or particularly if you didn't hear it, okay, we were doing cataracts and not hearing aids, but same concept. That memory is critically dependent upon perception, that if you didn't perceive it, it didn't happen. Okay, did you see the man in the green shirt? No, well, he doesn't exist as far as you're concerned. And therefore, there's no way you could remember his name because you didn't perceive him. So we did a study of about 80 people with intermediate surgery versus delay of surgery for 6 months. First thing is to know is that in the Alzheimer's population, it does actually improve visual acuity. It does what it's supposed to do. That's great. Again, we saw with early intervention, the immediate surgery versus the delayed surgery. Again, wasn't that these guys did so well, is that there was a much larger decline in the people who were in the control group. Okay, so somewhat similar to what we saw with Aricept. Interestingly enough, neuropsychiatric symptoms went up much more in those people with the delay, but caregiver distress went down relative to, so that this had benefits not just on the person, but on the caregiver. Where do we go from here? There's a new model for how to think about Alzheimer's disease, and this involves coming out of the Alzheimer's Disease Neuroimaging Initiative, this idea that there's a very long preclinical tail to Alzheimer's disease, that we are up to 20 years. And you see it both in familial and non-familial forms of AD. Was seen in the Diane study as well, that the amyloid is the first thing that happens, and that MCI and dementia are really the last stages of a very long process. So this could be up to 20 years. And so this is like trying to understand kidney function by looking at people on renal dialysis. They're at the end stage, they're not at the beginning stage. Now, what sets off the amyloid cascade? That's an important question to which nobody really has the answer, but amyloid and then tau, and tau is a much better marker of neurodegeneration, as we'll see in a minute, and then MCI and dementia with neurochemical failure as a late finding in. So if we're really interested in early intervention, which we think works in many other conditions, it works in congestive heart failure. We don't wait till you're gurgling up pink fluid. It doesn't wait. It works in sepsis. You don't wait till you're hypotensive in the ICU to give you antibiotics. It works with cancer. You wouldn't say that the pea-sized tumors, we'll wait till it's a lemon-sized tumor or a grapefruit-sized tumor in order to intervene. You'd run the other way. So the idea of early intervention of people who are amyloid positive or elevated amyloid, as more technically correct, in a preclinical model or prodromal Alzheimer's disease is really the way that the field is going. And to some extent, and it's unfortunate, is the people in nursing homes, they're being sort of left behind because they're viewed as impossible. It's not going to really change anything at this point. Now, the utility of removing amyloid that might have been there for 20 years, that's an important question, especially as we move into the age of biologicals with monoclonal antibodies. And it has been actually fairly difficult to show functional improvement even in the early stages. One of the things that's really changed how we look at this is it's been well known that in clinical trials of AD, up to 20% of people did not have Alzheimer's biomarkers, is normals with elevated cortical amyloid, as shown here. This is the basis for the so-called A4 study, which is the anti-amyloid drug in asymptomatic Alzheimer's disease, and you can see that going on. So this is an important point. On the other hand, tau parallels AD phenotypes much better, and you can see here in somebody with posterior cortical atrophy, the visual spatial, you can see the elevated tau in the cortex here in the left parieto-occipital area, and here in the posterior cingulate area, and as shown here. Then somebody with logopenic PPA, which is a form of primary progressive aphasia that's most associated with beta amyloidosis, is associated with much more in the left than in the right. Again, the showing a proper anatomical distribution. And lastly, somebody with amnestic AD, we know that the beginning of tau deposition starts in the entorhinal cortex, as shown here, a little bit more on the right side than on the left side. So we'll, this is an inversion of in vivo Brock staging. As far as I'm concerned, this is science fiction compared to where we were in the 1980s. And this is why we really need a new Alzheimer's disease, because so much of our nihilism, ambivalence, denial is related to this disease that we can't diagnose, which we can't do anything about. As you see, we can do things about it, and we can actually diagnose it with high reliability in the living patient. Brain health is an important concept, and there's been a number of interventions around brain health. In my understanding of brain health is that it's really a wellness model, and a wellness model across the lifespan. And so what I went and did is, I'm not a big fan personally of organ-specific health, but I went and looked at brain, lung, skin, bone, breast, eye, and prostate health. And every last one of them said, don't smoke. And most of them said that you should stay active, but also avoid trauma. Okay, avoid infection in your lungs, avoid pollutants that can traumatize, treat your skin gently, protect yourself from the sun, from UV radiation. You see the same thing with eye health. Whoops. Eat for plenty of, diet plays a role there, but there are two things that are unique to the brain that are, so that there is some specificity to this idea of brain health. The first is adequate sleep. Sleep, I mean, probably every organ in the body sleeps in slightly different manners, but sleep is universal across the animal kingdom and very important. So adequate sleep, which is a brain function, is important. And the second is this whole idea of social engagement and brain games. Then this is, you know, the data on it is a challenge. But the idea is that to utilize the brain and the use of a lucid theory to some extent here. Now I'm going to talk a little bit about the SPRINT study again, the hypertension study, because this is a model for prevention of lowering the risk of mild cognitive impairment. The SPRINT study was 140/90 versus 120/80. It was in several stages. The study was stopped early because of markedly lower mortality and morbidity on the hypertension-related outcomes. The first thing you're going to learn if you do a study about blood pressure is no delta, no study. So this was followed extremely carefully throughout the entire study, and so it's that was an important piece of it. This is from the JAMA 2019 article, which we showed a hazard ratio of 0.81 for the incidence of mild cognitive impairment, a 19% decrease. Now, unfortunately, the pre-specified analysis had it as lowering a dementia, and because it was stopped early, the numbers were not there. So it was in essence, was a negative study in some regard, but we see that the lowering of the composite of now this was also all-cause dementia. This was a group with high vascular load. This was not AD. We did not do imaging. We did do imaging, but not in everybody. But so this was all-cause dementia. You can see, and this is partly a factor of how studies are done, that they're done with 5-year time periods. And you can see that at 5 years, it takes 7, 8, 10 years probably to tell that an intervention is going to be useful. The same with the brain games, the speeded tasks. That was done at over 11 years. So it's not enough to do Sudoku for a week, a month, a year. You have to be engaged. You have to want to do it. It's a very long-term proposition. There was some interesting MRIs. There was an MRI subgroup of about 650 people. And we saw in the intensive group, a much lower progression of white matter changes in the white matter lesion volume in the intensive treatment compared to the standard treatment with a p-value. Now, although it was not statistically significant, it is a little worrisome, and it's been found in other studies as well, is that the intensive group actually lost a little bit more brain volume and there's no good, I haven't seen a really cogent explanation of why that should be. Now, SPRINT is a great thing, and many of us who do clinical trials have never really done a positive study, and it's great to see that not only was it NIH Trial of the Year, but it actually translated it into public policy. So the definition of high blood pressure and when to start treating it at 130/80 compared to 140/90. So we know that like cholesterol thresholds that has changed over time. So blood pressure as a result of the SPRINT study, I think directly, there was a change in public policy. Now I'm going to finish up with aducanumab. I hope I have a few more minutes. Approved by the US FDA in June 2021. We're going to look at some of the data. There's been a huge backlash mostly by the investigators, and 3 of the people on the committee that voted not to approve it, including Dave Notman from the Mayo Clinic, resigned from that committee because nobody listened to them. And then labeling has already been changed because it showed, although people were in that study had MCI and were very early, the labeling came out with Alzheimer's disease. Are we going to be giving aducanumab to people in nursing homes? Well, probably not. It also came out that the cost of it in the United States would be estimated to be $22 billion a year, which is about the same as what NASA, the National Aeronautics and Space Administration, costs. There were 2 studies, Engage and Emerge and Engage. Now, we talked about doing studies and testing different diverse populations. And so Dr. Chahidi and his group and Marrakesh, you see that Morocco was not one of the sites. So does it work in that North African Arab population? Well, there's really no data. You know, there are cultural and physical differences between cultures and the expression of Alzheimer's disease. You see it was done in Japan, but nowhere in Africa, nowhere in South America. Most of Asia was excluded as well. Does it do what it's supposed to do? So there's no doubt that it removes amyloid, okay? This part, I don't think there's any doubt that aducanumab removes lowers cortical amyloid as assessed with PET scans. CSF biomarkers also changed. I don't think there's any real doubt about this. Engage was not as statistically significant, and this is part of the problem with this approval, which is that it should take 2 positive trials, and only Emerge was truly positive and not Engage. Now, this is the clinical dementia rating scale, some of the boxes. You can see by 78 weeks, almost everybody is worse than when they started. Okay, we have to understand this, that people are not going to, this is not going to turn back the clock. Now there's a difference. Again, that was similar to what we saw with Aricept and with cataract removal, but here's the placebo group. They're not doing so hot. There were some changes. Again, I've asked the company about this, why these are presented as percent changes rather than real differences. And again, the differences are actually fairly small. So so it's nice to show them as percentages. How important they are is a little bit unclear, whether it's functionally important. Lastly, in changing was the amyloid-related ARIA, amyloid-related imaging abnormalities, which comes in 2 flavors, ARIA-E for edema and ARIA-H. And this is, to my mind, although many people can go back on the drug, this is not a trivial problem and really needs to be watched for quite carefully. And so the number of safety MRIs was also decreased in the labeling here for aducanumab. You can rarely get, there are some people who are not on amyloid lowering drugs who've developed edema and hemorrhages in the form of hemorrhage and cerebral microbleeds and superficial siderosis. How common is this with aducanumab? Well, it's fairly common. If you look at the total number, 30% of people had developed either edema or hemorrhages. It was not that often a serious adverse event in the sense of death or hospitalization, but it affected, due to ARIA, about 6% of the people dropped out. So this is really, it's not, I don't think, we tend to be somewhat risk averse, but I don't think that this is necessarily a good, I think it's not a good thing. And we have to be cautious, and we're certainly hoping that new and other better drugs will come along, although this sends a very strong signal to the pharmacological community that you can get drugs approved on the basis of biomarkers with less clear indication of functional improvement. That ends the slide, so that will end the talk, and thank you very much, and I'll take questions during the question and answers.
Thank you, Professor Lerner, for this interesting presentation.
You're quite welcome.
Ladies and gentlemen, please postpone your question until the end of the second presentation. And now, may I introduce our second speaker, Professor Jacobs. Professor Jacobs, he received his BS degree from David's College, North Carolina, and a PhD in molecular biology from Washington University. He has been involved in the healthcare industry for over 25 years and has extensive expertise in supervising drug manufacturing operation and the design and implementation of preclinical animal trial and US FDA authorized clinical trials. He started a new department of biology chemistry at the pharmaceutical company Merck, and for 15 years worked at the chief science officer of cardiovascular biotherapeutics, where he oversaw FDA authorized clinical trials in which the angiogenesis drug candidate human FGF1 was tested in a number of medical indications, including coronary artery disease, diabetic foot ulcers, and peripheral artery disease. He has been continuing these drug development activities with FGF1 at Genesis Medicine, concentrating on the potential role of therapeutic angiogenesis to treat neurodegenerative disease, including Parkinson's disease. Professor Jacobs, you have 30 minutes to talk about novel therapies of Alzheimer's disease employing therapeutic angiogenesis. Professor Jacobs, the floor is yours.
Thank you very much. I'd ask maybe Dr. Lerner to take his screen off, if that's possible. I'll put mine up. Okay.
Am I still sharing? Okay. Stop my share. Okay, sorry.
That's all right. Okay. I'm not seeing my screen share. Shahidi, could you help out here? I'm not able to get my PowerPoint up.
Can you try now to share your screen, please?
Okay, there it is. Thank you.
Yes, I'm allowing you, Jack, to share your screen. Okay, great.
Okay. Thank you very much, Shahidi, to present this somewhat novel approach to a potential treatment for Alzheimer's. I'm going to talk about therapeutic angiogenesis. And what I'm going to do is review the drug we're developing that stimulates angiogenesis. Talk very briefly about some FDA clinical trials we've done in patients with heart disease, and then go on and lay out a scenario, a strategy whereby we think stimulating new blood vessel growth in the brain may have a potential use in treating neurodegenerative diseases. Okay, just to remind you, 60,000 miles of blood vessels in our body. Every inch of these blood vessels was formed by the process of angiogenesis. And the drug we're developing is a protein biological drug, which is probably one of the most potent stimulators of angiogenesis in our body. So let's just review briefly. There are over 75 human diseases that result from a lack of blood flow to an injured tissue or organ. Some are very obvious, ischemic heart disease, stroke. But a number of researchers are now publishing that neurodegenerative diseases such as Parkinson's, such as Alzheimer's, may have a vascular etiology. And so we'll review some of the literature on that, and then review some of the preclinical data we've gotten with our drug, which we believe is going to allow us to go forward to begin human testing in a Alzheimer's disease population. Okay, so angiogenesis, normal process. We use it all the time. We use it, this is wound healing. So let's look at that injured skin. Look under this, let's say this is a scab. So here's angiogenesis at work. These are brand new microvessels, blood vessels, stimulated by this drug that we're developing. And this will regenerate skin. Skin is an organ, not only skin cells, but hair follicles, sweat glands, nerve cells. So this is a regenerative process. And we've done this in the heart, which I'll show you next. And we believe we also can do this in the brains. And I'll show you some preclinical data which supports that. This is the drug. It's called FGF1, fibroblast growth factor 1. It's a protein. This is a three-dimensional structure. As a graduate student at Washington University in St. Louis, I actually helped purify this from cow brains. We don't use cow brain FGF1 anymore. We produce it in an industry standard way. This is an FDA-inspected biological manufacturing plant that we use to make the FGF1 for our clinical trials. So here's the process of FGF1 stimulating angiogenesis. So when that skateboarder fell and cut his elbow, his body made FGF1. FGF1 then binds to FGF1 receptors on blood vessels. That starts a cascade of events. Endothelial cells begin dividing. You get degradation of the basement membrane. And here we see the beginning, formation of a brand new blood vessel. It's a tube, elongation directionally into the injured area, bringing blood perfusion into that wounded area, stimulating the regeneration process. One important thing I want to mention is only in injured tissues, only in ischemic tissues, do we see an upregulation of the FGF1 receptor. So if we've done this, inject FGF1 into normal, let's say normal heart tissue, we get no angiogenesis, no blood vessel formation. You need to have ischemic heart tissue where the FGF1 receptors are upregulated. We then introduce therapeutic amounts of FGF1, we see angiogenesis. So let me just show you. This is a phase 1 clinical trial that I supervised. These were patients with severe coronary artery disease. They were not eligible for a bypass or stenting. In the first trial, we made actually a small incision, a mini thoracotomy into the chest, and directly injected the FGF1 into the heart muscle. So that was important. Many other clinical trials before ours had tried intravenous growth factor therapy or intracoronary growth factor therapy, but did not work. It was only when we directly injected the FGF1 into ischemic heart tissue did we see a new blood vessel formation. I'm going to show a short video rather than me show you data. We had 6 clinical trial sites, and the ABC News came to our University of Cincinnati clinical trial site, interviewed some of the patients and the cardiologists there. And they're going to show you some angiograms of patients' heart that were treated 12 weeks after the treatment. And look carefully, Dr. Lynn Wagner, the cardiologist, is going to be pointing to this blushwork of brand new blood vessels, which grew in these patients' heart and which allowed them to perform much better on treadmill testing. So here's a video. I won't talk through it, but I'll come back to you at the end. It's short. It's only a minute long.
But since receiving an experimental treatment for his blocked arteries, his pain is gone.
I really feel great.
Duke was one of the first heart patients in the country to be treated with a protein actually capable of growing brand new arteries. The genetically engineered protein is injected directly into the heart. Within days, a network of new vessels begins to grow around the blockage, increasing the blood supply. Dr. Lynn Wagner showed us the changes in one patient's heart.
We see a small, narrow main artery and not very many secondary and tertiary arteries. This is after the treatment. What we're now seeing is new blood vessels growing here off the end of this artery.
And the patients themselves?
Symptomatically, they're improved within a couple of weeks of the treatment.
Just ask Constance Donnelly.
Oh, I feel wonderful. I've never felt so good in the last 5 years.
But doctors already see potential in other cases where the blood supply needs a boost, such as strokes and diabetes.
So we're continuing these studies. We actually are using now a Johnson & Johnson cardiac injection catheter. So we're not doing a surgical. We are using interventional cardiologists now go up through the femoral artery and actually to inside of the heart, where we can make up to 20 injections of this growth factor in the same patient population. So just wanted to show you this. We can grow blood vessels in the human heart. And now I want to lay out kind of a strategy. I'm going to provide kind of ancillary preclinical data, which we think this approach may have merit to try in neurodegenerative diseases, including Alzheimer's. This is a publication. Actually, Dr. Lerner referred to this, the Alzheimer's Neuroimaging Initiative. To us, this was a very seminal paper kind of pointing out that Alzheimer's may have a vascular etiology. So this was the early role of vascular dysregulation in Alzheimer's disease. And the authors concluded that vascular dysregulation may be the earliest and strongest pathological factor associated with late onset Alzheimer's disease development. So basically, this was a large study. It came out of McGill University in Montreal, and they followed a number of biomarkers in 1,000 patients, a very large study, looked at over 7,700 brain images. And these are the type of biomarkers they were looking at. These are looking at abnormalities in these biomarkers. So beta amyloid, glucose metabolism by PET. Importantly for us, they looked at blood flow, and this is with a functional MRI type of imaging modality. And they looked at memory loss as well as structural properties. And they basically looked over a 30-year span, so patients covering a 30-year span of Alzheimer's disease, and they looked at what abnormalities came up first. And this is a busy slide, and actually Dr. Lerner showed a similar one. This is from the Nature paper, looking at disease progression with aging, going from healthy controls. This is early mild cognitive impairment, late mild cognitive impairment, and then out here at the end is late onset Alzheimer's disease. And they've followed these biomarker abnormalities, beta amyloid, memory, vascular, again by functional MRI. And the very first abnormality that showed up in this study was vascular dysfunction, okay? There's a brown. This preceded amyloid deposition, memory loss by quite a bit. So to us, working with a growth factor which can increase blood perfusion, this got our attention. And we started thinking about the possibility of using a growth factor which can increase angiogenesis in the brain as a potential strategy to undergo clinical testing in an Alzheimer's disease population. So let me show you some of the preclinical data. We don't have it in an Alzheimer's model, but I think we have enough corollary data in other animal models involving the brain that I think I can put together, hopefully, a somewhat convincing story why it makes sense to test this in neurodegenerative diseases. Let me just show you some data from an animal model of stroke where we can tie off We tie off the middle cerebral artery in the mouse's brain. This is a human, not a mouse. And then we can treat the animals with FGF1. Show you some of the results from that. So we're looking here, this is normal mouse vasculature. These are capillaries on the mouse's brain. We give the animal a stroke. You can see the decimation of the vasculature in the area of the stroke. We then treat for 14 days. This is intravenous treatment with FGF1. The animal's treated with FGF1. We can see a nice regeneration of the brain vasculature in that area of the stroke. Not quite back to normal, but certainly better than the placebo-treated animals, where we see regrowth of the microvasculature in an abnormal way. We have clumping of these vessels. These are actually hemorrhaging more than here. So, and we can infer that we are improving neurogenesis and neuronal regrowth by doing some motor skill testing on these mice, and that's done on this rotating bar test. So this bar is rotating, normal mice grab on easily. Here are our stroke mice that were treated with FGF1, grabbing on not quite as well as these guys, but placebo-treated animals can't hang on to that rotating bar at all. So from these preclinical tests in the stroke model, we know with IV dosing, we can regrow blood vessels in the brain. We infer we're regrowing functional neurons by this motor skill testing. Okay, this is not our work, but this is work coming out of a number of labs, and neurologists at the University of Southern California advanced theories that in neurodegenerative diseases such as Alzheimer's and Parkinson's disease, there's changes in the blood-brain barrier, which are behind the etiology of this disease. This just shows how the blood-brain barrier breaks down as we age. This is MRI imaging, enhanced imaging, looking at human brains as we age. And you can see here, this is leaky blood-brain barrier, kind of a breakdown of the blood-brain barrier, showing up leaking of blood components into the CSF. Mouse brain, similar thing you can see. It's not quite as clear as in the human brain, but here again, this is showing breaking down of the blood-brain barrier. So what is behind this breakdown? We and others think it involves disruption of the tight junctions of the endothelial cells that line the brain microvasculature. And there's a syndrome called endothelial cell dysfunction, and we can see this in aged mice. These are brain capillaries in a healthy animal. We see the endothelial cells lining, the blood vessels are tightly packed, not leaky, but when they develop this primary endothelial cell dysfunction, the endothelial cells become a bit disformed and these become leaky. Now, what do they leak? Well, they leak things out into the brain that shouldn't be outside of the vasculature. They leak coagulation enzymes. Fibrinogen gets out. Fibrinogen can coat adjacent neurons. Immune cells leak out, and the immune cells recognize those fibrinogen-caked neurons as foreign, and you get inflammatory responses and basically an autoimmune response. And some neurologists feel this type of leakage and immune response could be behind such diseases as multiple sclerosis, which is thought of as an autoimmune disease. So we've tested FGF1, again, in an animal model. This is an animal model of multiple sclerosis, where capillaries from the lesions of the animals can be removed and looked at. Here we see this endothelial cell dysfunction, this kind of gross abnormality leading to leakage. And when we treat those animals with FGF1, we can see healing of this endothelial cell layer in this animal model of MS. So we get tight junctions again out here at 30 days. We can look at that histologically. So leaky vessels, and here we see basically a restoration of the blood-brain barrier in these animals that have been treated with FGF1. So we feel two things now. We have growth of new blood vessels, angiogenesis, which FGF1 can stimulate, but also healing of these vessels that are suffering from this endothelial cell dysfunction. A third thing which I'd like to talk about is, this is not our work, this is work from Columbia University, published, very prestigious journal, Cell, looked at neurogenesis through aging. And they looked at people who had died in accidents and looked at neurogenesis at different ages. And what the study showed is that neurogenesis continues out till we're 80 years of age. But what doesn't keep happening, what declines, is importantly angiogenesis, and these pools of active stem cells begin to shrink. So basically the study concluded that you need proper blood perfusion for neural stem cells, so the pools, to differentiate into functional neurons. And actually a short video was done on this study. I'd like to show it to you, where they're looking at hippocampal stem cells and how they decline in activity as we age. And this is thought to be behind the cognitive impairment, the memory loss that we see with age. So let me just run that for you real quick. This is the Columbia University study. So again, just supporting data, blood perfusion, angiogenesis is important, maintaining proper neuronal function. Finally, I'd like to end up with some data that we've collected in a primate model of Parkinson's disease. And this relates to clearing plaques that are seen in Parkinson's disease. So as Dr. Lerner mentioned, hallmark of Alzheimer's is these beta amyloid plaques. These are cleared by that controversial drug that he was talking about. We can give monkeys Parkinson's disease by injecting a toxin, herbicide, paraquat-like toxin, into the brains of these animals. And they come down after about 5 months with all the classical symptoms of Parkinson's, gait disturbances, tremors. They also develop alpha-synuclein plaques in their brains. This is a hallmark Parkinson's, Lewy body disorder. And we've treated these animals with FGF1 for a period of 6 months intravenously. We looked at motor skill improvement, but we also importantly looked at this aggregated synuclein in the substantia nigra region of the brain. This, as you know, is where housing the dopamine producing neurons, the ones that are affected in Parkinson's disease. And here's the alpha-synuclein aggregates in the monkey's brain. And these are the alpha-synuclein aggregates. You can see we've cleared a substantial number of these aggregates from the brains of these monkeys that have been treated with FGF1. Maybe not quite back to normal, but certainly better than this situation. We also looked at regeneration of dopamine-producing neurons in the brains of these primates. And these dopamine neurons stain brown. Again, this is slices of brain through the substantia nigra nice regeneration of dopamine neurons. We don't see that in the placebo-treated animals. So we're excited about this. We've actually been given approval to start a phase 1 clinical study in Parkinson's disease, as well as ALS, motor neuron disease, using intravenous treatment of FGF1. And we're now preparing an application for the FDA to test FGF1 in a phase 1 clinical trial in patients with Alzheimer's, kind of using all that preclinical data that we've gathered. We're not sure if they're going to go for this. They might want us to test something in an animal model of Alzheimer's, but we're going to give it a shot. We're going to propose 3 ascending doses of the FGF1 drug. Patients will receive a 1-hour IV infusion of FGF1 5 days a week for 4 weeks. If you give bolus injections of FGF1, you can induce hypotension. So we've got it delivered over a 1-hour period. We're going to be using 2 imaging modalities to look at blood perfusion in the brain, PET and MRI, and then follow-up visits out to a year. So this is a relatively short study, and it's mainly for safety. Phase 1 is mainly for safety testing, but we will see if we can see any changes in perfusion. PET imaging, Dr. Lerner actually showed the same slide. This doesn't look at perfusion, but looks at metabolic imaging, glucose uptake. But we can use functional MRI to look at blood perfusion in the cortical regions of the brain. It shows a woman with dementia. Blue is normal perfusion, yellow is less, and red is severely reduced blood perfusion in these areas of the brain, which line up with cognition, executive function. So we'll be following those 2 markers. We're using a PICC line to introduce the FGF1 near the heart, and we think that will aid it in getting into the brain. About 5% of the drug gets into the brain in animal studies. So dosing IV, about 5% makes it into the brain. And we've also gotten some very nice recent data where we can deliver FGF1 intranasally, and mainly through the olfactory bulb. It gets retrogradely transported back into the brain. And we're just quantitating how much FGF1 can get in that way. But certainly intranasal delivery would be a much easier way to run a clinical trial. And in fact, there are intranasal delivery devices. This one was actually used to deliver insulin. Insulin was used on a number of clinical trials in an Alzheimer's disease population, and they successfully got insulin into the brain using that device. So we're excited about that. We're, again, starting 2 trials with Parkinson's and ALS, and we'll know maybe in 4 months whether we'll be allowed to go into an Alzheimer's disease population. If you have patients or want more data about our clinical trials, you can go to our website at zgm.care. And any entrepreneurs out there, you can email our CEO if you have any partnering ideas. So with that, I will stop and turn it over for questions and answers.
Thank you, Professor Jacobs, for this interesting and nice presentation. So let's go to the audience for any questions. If you have any questions for the 2 presentations, our professors will be pleased to answer.
Okay, I see some questions that I can answer.
FGF, I have 5 questions at this time.
Okay, do you want me to read the questions, Shahidi?
So FGF1, what would be the dose and the total cost for 1 patient, please?
Okay, so we have,
yes?
Yeah, the dose is a weight-adjusted dose, so we'd start at a fairly low dose, 1 microgram per kilogram, and the high dose will be 10 micrograms per kilogram. 10 micrograms is basically what those monkeys got in that study. No cost for the patient. Clinical trials.
FGF1, what would be the dose and the total cost for 1 patient?
Yeah. So the dose is between 1 and 10 micrograms per kilogram. It's a weight-adjusted dose depending on the weight of the person. And the cost is no cost. We pay all costs for a clinical trial. so there'd be no cost to the patient.
For the second question, we have how do we know the vascular dysplasia stage in order to start FGF1 for Alzheimer's disease? It is the breaking down of the blood-brain barrier and finding the produce.
Yeah, so we'll be using the same type of MRI that was used in the McGill study. It's called arterial spin labeling. It's a functional type of MRI where you can look at blood perfusion in the brain, and that'll be done baseline as well as a year out in these patients that are treated.
Let me add that this is a very important area of research about endothelial senescence and other, the integrity of the blood-brain barrier in Alzheimer's disease and in other related dementias is a area under intense investigation. Now, we also know from the COVID experience that the integrity of the endothelial layer is a major factor in the COVID-related encephalopathies.
Sure. Good comment.
Second question, Omar Zouk.
Another question, how often macrovascular risk factors like diabetes, hypothyroidism attributed to impaired angiogenesis in mild cognitive impairments with amyloid or tau deposition?
I can answer part of that. I think Dr. Lerner could also chime in. Most of my data comes from that McGill imaging study where they looked at the biomarker abnormalities and again, saw decreased angiogenesis, blood perfusion as a very early symptom, as a biomarker for patients that then went on to develop Alzheimer's.
Yeah, to supplement Dr. Jacobs' answer here, I don't know about hypothyroidism. We do know clinically that diabetes increases the risk of Alzheimer's disease quite significantly, and whether that's type 2 or type 1. And the mechanism of that is not clear. Some of that is thought to be insulin and IGF signaling in the brain, but the role of the endothelium, which is damaged in diabetes, is also of importance here, but I can't give a number or anything of that sort.
It is an interesting question. What do you think about the future of the vaccine in the Alzheimer's disease?
Well, various vaccines have been tried. The original vaccine from Dale Schenck in Elan originally showed that it actually reduced amyloid quite significantly, but there was stopped because of the intense immune response, and that is why people went to monoclonal antibodies and indirect augmenting immune function that way, rather than with it was felt that there was too inflammatory the response to a vaccine, quote unquote.
What is the differences about aducanumab from other monoclonal antibodies tried in the past? What is the difference about aducanumab from other monoclonal antibodies tried in the past?
What is the difference? They all of them have slightly different. This is an interesting question. Everybody thinks they have the best target. There's a number of different targets that have been proposed, and it's hard to know what the active toxic moiety or toxic chemical is in amyloid. Is it free amyloid? Is it truly the amyloid plaques? Are we interrupting deposition of amyloid? So I think that it depends on the antibody. I know that the donanemab has something to do with glycation at the end of the, but I'm not unaware of the exact mechanism of action. Maybe Dr. Jacobs can help us here with aducanumab.
Yeah, no, I think you know that area better than I. How it removes the beta amyloid is the mechanism?
I'm not clear about that.
Yeah, no.
I mean,
never mind.
it's easily up, but it's not really at the topic.
I know they've discovered a lymphatic system in the brain. Maybe that's involved in clearing it, but who knows?
Another question: if there is an if GF1 decrease amyloid and tau protein, if there is an effect of FGF1 in decreasing amyloid and tau protein.
I certainly hope not, but we do not know the answer to that question, and I'd certainly be surprised in those primates. It didn't obviously increase synuclein. Aggregated synuclein tangles in the monkey's brain, but I don't know the answer for that in amyloid, beta amyloid models.
Our last question: at what time you arrested the medication in Alzheimer's disease? And in your practice, what is the place of the cognitive rehabilitation?
I think we try to intervene as early as possible. I think that there is some evidence that neither cholinesterase inhibitors nor NMDA receptor antagonists have much effect on mild cognitive impairment. On the other hand, the monoclonal antibody efficacy in people with established dementia has not been shown, and really the best results have occurred in preclinical models, such as MCI, or even before MCI, really looking at amyloid, people with elevated amyloid who are cognitively normal. Cognitive rehab has a place. We have hired a new division within my center of cognitive rehabilitation. Now, this has gotten most of it a history of from traumatic brain injury and for stroke. I think there is a role for cognitive rehabilitation, particularly in some of the language variant, some of the cortical variants of AD, such as primary progressive aphasia, as well as posterior cortical atrophy, where cognitive rehab may be of more value. The question in sort of garden variety Alzheimer's disease with hippocampal dysfunction and amnestic features is, the jury is still out on that one. I don't know that we can say, but it is, the other thing that we use to try and slow the process down is a high dose of vitamin E. The dose of 1,000 units twice a day was used for many years. There was some suggestion of increased in neoplasms and heart disease in epidemiologic studies. So we settled on 400 international units per day, and alpha tocopherol had the same effect basically as selegiline, which is an MAO-B inhibitor.
Thank you, Professor Leonard. Thank you, Professor Jacobs, for your answers and your very interesting presentation. Mr. Saidi.
Yes, I'm here. So I would like to thank Professor Lerner for joining us for this interesting webinar on Alzheimer's disease, and also Jack Jacobs for your support and continuing programming and education, and looking forward to seeing you among us the dear colleague for the upcoming webinar on multiple sclerosis. Thank you so much.
Thank you.
Thank you,
Pleasure.
Shahid.
Thank you.
Professor.